Hi there, I'm Mabel Chen, and this is One in a Billion, part 2 of our special series, True Colors. True Colors is about the color of our character, not our skin in times of crisis. How we respond reveals who we are and what we care about. This season, we interview Asians and Americans, especially our friends who are in the Black community, who are fighting for racial justice as they confront the coronavirus. Today, we talk with 2 Asian American doctors about finding humanity in emergency.
I'm in an emergency training program, and I'm finishing my 3rd year of 4 years of residency. And I found myself often crying behind my own mask, or, I would be on the verge of tears, and then I would have to suppress them because I knew that I needed to be in full control of myself and my ability to perform a procedure like putting someone on a ventilator.
That is Dr. Anita Chary.
I finished residency in 2007, and I think the entire medical community has evolved since then to recognize the stress that happens in hospitals and emergency departments every day. I've had more life experience. I've recognized the humanity in all of this and try to make a personal connection with patients when I can.
Dr. Anita Chary and Dr. Chen both worked at Boston's Brigham and Women's Hospital at the peak of the pandemic. How has their job changed? How are they changed as ER doctors, as a dad with 2 kids, and as a wife and a daughter? Here's our conversation. So I want to begin the interview by taking you back to April when Boston was in the middle of the surge with COVID-19. The numbers are grim. There are like 1,500 new cases of infection a day, and 10% would die. And you work in the ER room. So what was the scene like around you?
There was a period of time where we would have patients back to back coming in with respiratory complaints. They were really short of breath. Many of them were very, very sick. And then there would be days where we would have very few people coming to the emergency department.
I'd describe the scene as just being somewhat surreal. On the one hand, you had this big concern and almost fear about, patients with COVID coming in. Everybody was in personal protective equipment, everybody in a mask. Emergency room routine was really upended. It's a very strange time.
We use an electronic medical record, which lists the names of the patients as they arrive on a board that all the providers can see. And when folks were thought to be at risk for a coronavirus, their names would get flagged in red. And so for the end of March and much of April, our whole board just appeared red because all of these folks had some sort of symptoms that suggested they might have coronavirus.
Because the coronavirus is so contagious, as ER doctors, they have to follow a set of new rules to minimize their own risks of catching it.
Our natural tendency is to see the patient as soon as we can and as soon as they get there. There were suddenly these extra layers of thinking, is this patient stable enough where I could call them from outside of the room and help minimize my exposure to the patient, help minimize nurses' exposure to the patient, and also help, frankly, minimize the patient's exposure to us, because even if we were asymptomatic, we could be carrying coronavirus. So we would have to escort the patients into the emergency department in a secure way. People were 6 feet apart.
So in terms of preparation and exposure, how do you prepare yourself? How do you gear up, I guess, each morning, physically, mentally, psychologically, before you go to work?
I'm young. I'm in my 30s. I don't have underlying lung disease or diabetes that would put me at higher risk for complications. So in some ways, I feel like I've been very lucky to work and not have so much anxiety about my personal health. And things that we do when we get to work, we all use hand sanitizer as soon as we get into the hospital. I wear a mask personally, then I replace it with a hospital-approved mask once I enter. And then all of the hospital staff have a different entrance. So we go to that entrance, we get cleared to come into work, and then we report to the emergency department. And then with each patient, we decide whether we need to use personal protective equipment. So if they have respiratory symptoms or other symptoms suggestive of coronavirus, we gown up, we gear up, we have our goggles and masks on constantly. If we're going to be doing procedures like getting a swab or doing something that's an aerosolizing procedure, which puts more droplets and particles into the air, then we also wear a respirator, which is a special mask that keeps out those particles.
One of the toughest things for ER doctors to process is the wide range of COVID-like symptoms.
You could have some patients come in and be super sick, need to be put on a ventilator. Patients who were older or who had more comorbidities were more likely to have those serious complications. You still saw some young people. I heard about a couple of young pregnant women who needed to be put on ventilators for COVID. Also, at the same time, you would have people who were quite well and might have basically symptoms of a cold who would come in.
And before Dr. Chen would go in to see a patient, he stopped and asked himself,
do I have the right equipment on? Do I have the right mask on?
Did you have the right gear for yourself?
We did. I was part of the hospital planning for it. The people involved with obtaining equipment did really great work in trying to find the equipment that we needed. There was definitely fear among staff that we would run out based on what we were seeing in other parts of the country. In New York, you would see people who were wearing the same gown for days or, having to resort to putting on garbage bags and things like that. But fortunately, we were lucky and never had to resort to that. So I work at Brigham and Women's Hospital in Boston, which is part of a larger healthcare system, is now Mass General Brigham. We have a lot of healthcare in Boston, a lot of hospital systems. Fortunate that the people at our hospital were working so hard to make sure that we all had the equipment that we needed. One of our colleagues figured out how to 3D print a face shield, and we're able to, make a bunch of face shields so that we wouldn't run out of those.
Is it part of your medical training for your practice that you could be so calm and maybe even detached from all that surrounds you that seems so overwhelming emotionally?
I certainly think that we practice and we drill and we work very hard to maintain that calm and to stay emotionally in control of difficult situations clinically. I think despite that, with coronavirus, some of the patients that we would see would deteriorate clinically very, very quickly. And so even though we're very comfortable with critical care as emergency physicians, and that includes things like putting people on special medications to help their blood pressure stay up or placing people on a ventilator and managing the ventilator, I think there was a lot of anxiety among providers that people were getting sick very quickly in front of our eyes, despite the best efforts that we made and despite the things that we were doing for them medically.
This is hard for me to ask, and yet I wanted to put ourselves in your shoes a little bit and just to imagine your day and your work. When they are scared or when they feel like, or you notice is critical, what do you say or what do you do to assure them?
One of the things that actually became a bit haunting to me over the months of March and April were that I kind of developed a script of telling people that they were very sick and needed to be placed on a ventilator. And oftentimes the patients would arrive so sick that we had minutes to place them on a ventilator and kind of get everything in order. And I would often say exactly that to them. I would say something along the lines of, your oxygen levels are very, very low. It's very likely that you have coronavirus and it's making you very sick. And we need to admit you to intensive care and we need to put in a breathing tube and connect you to a ventilator. And then if we had time, we would try to have them call a family member, or something that we started doing more and more was actually making videos of people on our cell phones or on their personal cell phones that we could then send to family members later, so that our patients could record their thoughts before being placed on a ventilator if they weren't able to communicate with their family members.
Wow. Did you improvise that? Did you just start that naturally, spontaneously?
Part of the great thing of working in the partner system hospitals is that we have so many experts and specialists. And this is a practice that was really encouraged by our palliative care divisions and departments across the whole partner system. So our palliative care group basically gave us some tips on not only how to communicate with patients, but they were the ones who ultimately, I believe, received hospital approval to give us this ability to make videos of patients. And they were the ones who gave us the guidance on doing this.
At that point, when you suddenly have to videotape them because you think they may be gone any moment and try to quickly send it to their family, loved ones, how long had you been in your job as an ER doctor then? Did you feel like you had to quickly grow up?
I think that those have been some of the most powerful moments of practicing medicine for me personally. So I'm in an emergency training program, and I'm finishing my third year of 4 years of residency. And I found myself in those moments, often I was crying behind my own mask, or, I would be on the verge of tears, and then I would have to suppress them because I knew that I needed to be in full control of myself and my ability to perform a procedure like putting someone on a ventilator immediately afterwards. But I think that it certainly is an experience that makes many of us grow up, and it requires us to develop a lot of emotional maturity.
Emergency medicine is a specialty where you often don't take the time to feel those emotions. At least when I started practicing, I finished residency in 2007. And I think the entire medical community has evolved since then to recognize the stress that happens in hospitals and emergency departments every day. I think also as I've gotten older, I've had more life experience of, recognize the humanity in all of this and try to make a personal connection with patients when I can. And these are tough moments. Patients' family members weren't able to come in to the hospital with them, and so they were alone. So you were it for them.
Well, you were it for them, Dr. Chen. What do they look for in you, verbally, non-verbally, from you, that you can give? And what can't you give?
I think that they're looking for some comfort, some reassurance. It's a scary time for them. There's a lot of things going on, a lot of machines going on, a lot of people in the room doing things to them, and this is all new to them. You try to comfort them with words and let them know it's going to be okay, and we're doing everything we can to take care of them.
Well, you mentioned how fast-changing this is, this virus, in terms of how quickly a patient can deteriorate. Well, Dr. Chen, what actually surprised you when you thought this person's critical, but maybe not? Can that person turn around? Was there any good story you can tell us?
We were using our best judgments, and early on, the guidance was that, well, they can crash really quickly, and so you actually want to intubate them and get them on a ventilator sooner than later. But with time, we realized that maybe there were some things that you could do to stave that off and not have to put them on the ventilator. One thing was just the simple act of turning them from being on their back onto their stomach and chest would let them actually breathe a little bit easier.
During those moments when they may be scrambling or critical from your judgment, what do they look for from you that you can give?
One of the things that I would also do is ask people who their family members were and who they wanted me to call. Even though it's a very small gesture, I think it meant a lot to some of the people that I saw who were very critically ill.
I think it's the Harvard Gazette. You mentioned your Hindu upbringing and you have a philosophy of healing. So tell me more about that.
In my family, we always grew up with some sayings about the importance of serving society. And I think that during the coronavirus pandemic, many of those lessons that my parents and my religious community taught me have really come to the fore. And I actually think this has been, even though it's been a very difficult, challenging, and trying experience for so many people in society, I think it's actually been very reaffirming as a physician that we have a very important role to play and that we have truly a gift. It's a huge privilege to actually be able to serve society in this way and take care of people when they need us the most. And some of the mantras that my parents taught me growing up were things like hands that serve are holier than lips that pray. And so for people who have a difficult time committing themselves to religious rituals, I think within Hinduism, there's a philosophy that work is worship. And so if you are going and serving society on a daily basis, then that's kind of equivalent to prayer, or it can be a personal style of worship to work and to serve.
Wow. If I ever get sick, I want you to be my ER Dr. Chaudhry.
Oh, thank you.
If I get so lucky. Dr. Chen, how about you?
I don't have anything as spiritual as Dr. Chary. I don't have a religious background. Being able to make those connections with patients is what I enjoy, and what I take a moment and reassure them or make a personal connection with them and let them know that they're going to be okay. I think that's what they remember.
Is there any philosophy or practice, work ethic standard that you adhere to, or you say to yourself, or you quote, you cite to help you get through it, Dr. Chen?
Maybe I need to come up with one now, but no. You're there. We never close. We never turn away patients. Whatever shows up, you take care of it. And so you just kind of soldier on and move on, and do what needs to get done is how I think about each day, each shift that I work.
Thank you. Dr. Chaudhry, you said, I believe it is the Harvard Gazette interview, that death comes with being a doctor specializing in urgent care. But some of the unique aspects of this disease can still shake you. What are they? What still shakes you?
I made a list of the patients that I took care of in the emergency department with coronavirus, specifically those who had critical illness and needed to be placed on a ventilator. And the things that shook me were that some of them were actually in their late 30s and 40s, people that I would not have expected to get sick. And I think what has been difficult as a physician and as a physician in training is to revisit those lists and look at the numbers of people who have passed away. And sometimes the people who passed away are very surprising. They were young, they were in their 40s, they had young children at home. And that's very difficult to process. I think there have been pleasant surprises too, such as seeing that patients are taken off of the ventilator. In our medical lingo, we talk about intubation, which is putting in a breathing tube, and extubation, which is taking out the breathing tube. And so actually seeing that a patient who was over 70 had the breathing tube removed and was taken off of the ventilator and then eventually got discharged from the hospital, that was also really powerful to see.
We deal with death, and we expect that some of our patients are not going to make it because they were getting so sick that the decision was made to take them off the ventilator because they were basically near death.
Wow, I've never heard that before. Who makes that decision for them to be taken off the ventilator if they don't have a loved one nearby? And how is that made?
There were actually a few cases where in the emergency department, patients would arrive and be very sick, and maybe they were elderly and had several comorbidities. And we would actually get on the phone, typically with family members, to talk through different options. So there are some patients who, beyond a certain age, it seemed very unlikely that they would recover even if placed on a ventilator. And so we would have some of those conversations by phone with family members. And then the request of the family members would be, is there a way for us to see our relative? Because we don't want, they have told us before that they wouldn't want to be placed on a ventilator, but we would really like to see them in their last moments. And so we would actually bring an iPad into the room and have FaceTime or video chat between the family members and the patient.
Wow. That is one level of comfort, knowing that you provide that level of connection and also knowing that you have the family involved in that as much as possible, right?
Yeah, I think those were really very powerful moments, again, in clinical practice. And I think seeing talking with friends who are practicing physicians in Italy and China and in New York and areas that were really hard hit, they talk about those small human comforts that they provided to their patients at the end of life. And they talk about how their medical degree wasn't what served them the most in those few moments with their patients at the end of life. Many of us in Boston experienced similar dynamics.
Do you keep a list or a number of patients that you have helped to recover? And what do you see as the difference between those who survived and those who don't?
So I actually kept all of them on the same list. One thing that shook me was that it wasn't very clear what was making certain people survive and what led to other people declining clinically. Something that we're seeing across the nation is that minority communities are being harder hit by coronavirus. Being on the front lines, I was seeing a greater number of African American and Latinx patients getting sicker and going to the ICUs. One of the hard things about keeping those lists was just seeing that so many of the names were of people who spoke Spanish, or so many of the people were African American, kind of reflecting on those cases. These are people who are on the front lines of society just as much as we are because they're working jobs in delivery and restaurants and they're not able to socially distance.
We're still fighting it. What are some of the ways that this global pandemic has allowed you to see and to feel and to act beyond your job as an ER doctor on the frontier?
On a personal level, I think it has made me much more deeply appreciative of all of my close relationships. And I think our relationships with family members are things that we can sometimes take for granted on a day-to-day basis. But my parents live in another state, and I haven't seen them for probably 6 or 8 months. And it's hard going into this global pandemic, knowing that I'm unlikely to physically see them for many more months to come. And also being in a high-risk job, not wanting to expose them. And similarly, my husband lives in Houston, and we have not seen each other in 3 months. We both work in healthcare, and we're both at institutions and in jobs where we really can't travel. It risks exposing many people, and that has been really difficult. So even with video Skyping and kind of being on Zoom, I'm certainly much, much more appreciative of all of my personal relationships.
Wow. Yeah, that must be so hard. So practically speaking, what can you do? What's the plan? Can you plan?
It's been hard. I think the hope is that as society reopens, that maybe there's a chance of visiting. I think I'll see my husband sooner than I see the rest of my family members. It's
really part of the human condition that you wanna be social and be with other people. And so, it's been eye-opening to have that just taken away from you. This is, really the first time in my lifetime where, almost everyone around the globe is experiencing this.
What surprises you about some of the maybe creative ways that people have found to be in touch that gives you hope?
This pandemic has been just a response to it, both in the hospital and outside. I'll say that our hospital is a really complex place and many different stakeholders, but with this, everybody was on board. Everybody is willing to help out other people. You see that in society as well. People providing food for other people. People have reached out to other people to help them get through this. Has been really heartwarming.
There's so many small examples of ways that community is being created. Earlier on in the pandemic, we had nurses at Brigham and Women's Hospital who brought in, masks that a friend had sewn, or they brought in scrub caps that their neighbor had made and given them to distribute to people at the hospital. And they brought in, experimental 3D printed masks or face shields. And I think those sorts of innovations are really amazing, and they help you take pride in your community and in the willingness of people to help out others. So as a trainee, I rotate between a few different sites, is that sometimes the community members locally are just sending in food for us, and it takes you by surprise that, suddenly there's a whole really lovely meal for all of the ED staff. That's been really nice too, to just have that recognition that we're a part of something broader and that people value what we're doing, and we're also trying to give back.
Dr. Chary, do you see yourself as an ER doctor forever?
For me personally, it actually has been very career affirming. In emergency medicine, as Dr. Chen was discussing earlier, we have this outlook that whoever comes with whatever condition, we will be able to take care of them. We must respond. That perspective has only deepened and amplified in this crisis. I think the way that this has changed my outlook as a physician, but also personally, is just this sense of patience and compassion. With anxiety being high, it's so important to take that extra moment or to acknowledge people's feelings and anxieties and show that compassion.
As you get older, you think about life and that the value of it. I have, wife and 2 kids, and so you think about the things that can happen, and so it just makes you, appreciate things a bit more. All the things that you take for granted that you do every day, now it just takes on a little bit more meaning and significance.
But I think one of the coolest experiences to me of this whole time being on the front lines is that occasionally we will hear an overhead page about Operation Hope, which is a part of our healthcare system when a patient gets discharged from the hospital and they've recovered from coronavirus. And when that overhead page goes out, the patient basically goes through the lobby and in a wheelchair or in a stretcher, and everyone wears masks and everyone is, appropriately distanced. But there's sort of a parade of the patient leaving the hospital to go home, and whoever's available can stand and clap for them. And I think being able to participate in that has been truly amazing.
Dr. Chary, Dr. Chen, thank you. In our next episode of True Colors,
I won't let them forget your black skin, your posture, your laughs, your sincerity, the way you care for people, the way you nourish our souls. How dare they take someone so essential? I can't let this go.
That's Serena Gooseby. She's a poet and founder of the Rena Collective, her website about personal growth and joy. Stand with us. That is our next episode in 2 weeks. 1 in a Billion is
Brian Latwinowicz,
Yvette Yu,
Maggie She,
Leah Yen Jarrett.
And our lovely theme song is composed by Brad McCarthy. Let us know if you want to join our team of volunteers, help us plan events, pitch a story. Just go to our website, oneinaBillionVoices.org, and find us on Facebook, Twitter, and Instagram.